All right, everyone. Here is the final lecture for the Metabolism and Regulatory Disorder section. And I just really want to say thank you for everybody's patience. But here we go. And just a reminder, here are the chapters with this presentation coming from your MedSurg book. But I do recommend if you are a little rusty on any of your assessment skills, that you go into the fundamentals or your health assessment textbook. So very brief thyroid review. Again, it's a butterfly or shield-shaped gland, and it produces 3 hormones. So your triiodothyronine, or your T3, your thyroxine, your T4, and then calcitonin. And then just remember, T4 is not active until it turns into T3. And what T3 is responsible for is cellular metabolism. Calcitonin is the hormone that reduces plasma levels of calcium, and it does this by increasing deposition in the bone. Remember, we talked a little bit about this in pharmacology when we talked about osteoporosis. So for nursing, right, want to go through that nursing process, and the first part of the process is always going to be assessment. So for the thyroid assessment, you want to get a good health history, and in order to do this, it's really important that you know the signs of hypo versus hyperthyroidism, because you are basically going to pick out the things in the health history that may signal one or the other. Kind of like putting together a puzzle. Right? So if the patient says that lately they've been very cold, they've been depressed and gaining weight even though they aren't even hungry, then these all fit with hypothyroid signs. Okay. The next part is going to be the physical exam. You do want to palpate the thyroid gland. So again, if you're rusty on this, your health assessment or your fundamentals book are great to help you review the steps. So again, feeling the thyroid gland, you want to assess heart rate, you want to look at the abdomen, the skin, the nails, the hair. You want to assess for any paresthesias, any muscle aches or pain. You want to look at their eyes, right? Do they have bulging eyes? Do they have a goiter? Basically, you want to look for any physical signs of thyroid disease. And then with the diagnostics, you would be reviewing TSH levels, or they might do imaging such as ultrasound, biopsy. There's a lot of different iodine tests. There's a lot of different tests that we discussed in patho. If your patient does need a test that uses iodine, it is very important that you as the nurse assess if they are allergic to not only iodine but also shellfish. This table talks about different medications that may alter the thyroid test results. So again, you'd want to assess if they're currently taking amiodarone, aspirin, cimetidine, or any of these other medications on the list, because, as I said, they may alter the test results and not give you an accurate picture of thyroid function. So just to review, the things you will be assessing for, those hypothyroid manifestations. We're going to start with hypothyroidism first. So with hypo, as I said, everything goes down, weight goes up. So a lot of times the presenting symptom is going to be fatigue and depression. They may say they have weight gain with a loss of appetite, hair loss, sorry I spelled that wrong, brittle nails, thick dry skin. They might complain of a husky and hoarse voice, menstrual irregularities, loss of libido, bradycardia, hypothermia, cold intolerance, constipation, and of course, worst case scenario with uncontrolled hypothyroidism is a myxedema coma. Some potential nursing diagnoses related to hypothyroidism: they might have imbalanced nutrition, more than body requirements, constipation, activity intolerance, risk for imbalanced body temperature, deficient knowledge about the therapeutic regimen for lifelong replacement therapy, and then they may also have impaired memory. On pages 1516 to 1517 of your Med-Surg book, they show examples of nursing care plans for some of these diagnoses. But just keep in mind, this is not an exhaustive list. Goals for care with someone with hypothyroidism is going to be symptom relief, to attain and maintain a euthyroid state, usually with drug therapy, helping with positive self-image, and then lifelong thyroid replacement therapy. So medical management of hypothyroidism involves pharmacologic therapy with levothyroxine, the brand name Thyroid, being the mainstay, most commonly prescribed drug for hypothyroidism. We will talk in pharmacology about a couple others. Sorry about that. Just keep in mind that when someone's on levothyroxine, the dose is based on their TSH level, and they do need lifelong monitoring because the dose might need to be adjusted up or down. And they'll be able to tell when the dose is adequate because the symptoms will no longer be there. And a good sign that they have too high of a dose is that you'll see signs of hyperthyroidism. Some other medical management with prevention of cardiac dysfunction: people who have people who have uncontrolled hypothyroidism for a while are going to have elevated serum cholesterol, atherosclerosis, and possibly coronary artery disease. So the doctor, the physician or primary caregiver, is going to want to manage these things, possibly putting them on a statin or whatever the treatment may be. And then there's supportive therapy. Again, supportive therapy is talking about when there is severe hypothyroid or myxedema coma. So with that, they're going to need arterial blood gases, oxygen, depending on their O2 levels, and then passive rewarming with a blanket. This is much more beneficial than active warming with like heating pads and stuff. So you just want passive rewarming, slow rewarming, and you do so by putting blankets on them. Moving on to nursing management, right? So we've come to the implementation phase of the nursing diagnosis or the nursing process. The two important factors are going to be health promotion and patient education. So with health promotion, that involves screening for the disease in at-risk populations. And then with patient education, they need to know disease process, signs and symptoms of disease. They need to really understand that they are going to require a lifelong pharmacologic therapy. Then they need to know the signs and symptoms of medication overdose, measures to prevent skin breakdown, the need for a warm environment. They should also avoid sedatives, be aware of any drug interactions with the levothyroxine or whatever drug they're on. And then they need all this both written and verbal, so that way they have something at home to remind themselves if they forget something. This next slide is a chart on educating someone who has hypothyroidism. So again, basically, I already explained it in the last slide, but going through the impact of hypothyroidism and the treatments. Again, needing to avoid extreme cold temperatures until they're stable. Then they'll want to know any complications, the potential effects of hypothyroidism. This one's really important because it'll help reinforce the need for people to have their lifelong therapy. They need to relate how to reach the provider. They need to know any follow-up appointments or labs or imaging or anything like that. And then it's important to help them find sources of support, and then the health promotion, disease prevention, and screening portion of it. And then evaluating, the final step of the nursing process, we want to evaluate if their symptoms have been relieved. We want to evaluate if they're adhering to their therapy. Are they taking it like they're supposed to? With levothyroxine, they need to take it first thing in the morning, 30 minutes to an hour before they take any other medication or eat. So are they doing this correctly? And then, of course, that lifelong monitoring of TSH levels. So moving on to hyperthyroidism, a review of some of the manifestations you'd want to look over would be nervousness, irritability, and they're apprehensive. They might experience palpitations, tachycardia, and dysrhythmias. They'll have heat intolerance. They may have warm, soft, moist, flush skin, but then again, they may complain that their skin is dry and itchy. You might notice some fine tremors of the hands, exophthalmos, that bulging of the eyeballs, and then weight loss even though they've got increased appetite. Nervousness is usually the presenting symptom or what brings people in for treatment. And then some potential nursing diagnoses for hyperthyroidism: activity intolerance, risk for injury, imbalanced nutrition less than body requirements, ineffective coping, situational low self-esteem, anxiety, and insomnia. But again, this is not an exhaustive list. There could be a lot more out there. Okay, so we assessed, we diagnosed, and now we go into planning. With planning, we want to find out how we're going to relieve symptoms, maintain nutritional balance, and have them cooperate with their therapeutic plan. For the medical management, it's usually done by pharmacologic therapy, and then we'll talk on the next slide, surgery is another option. So with pharmacologic therapy, there's two choices. There's giving antithyroid drugs or radioactive iodine therapy. With your antithyroid drugs, the goal of these are going to be to inhibit one or more stages in thyroid hormone synthesis or hormone release. So they want to inhibit that release of hormone to decrease the amount of thyroid hormone in the body. With radioactive iodine therapy, the goal for this one is going to be to eliminate the hyperthyroid state by administering a sufficient amount of radiation in a single dose. It's important to know that radioactive therapy is contraindicated in pregnancy, so they usually have to have a pregnancy test within 48 hours. And then they should not conceive for at least 6 months after surgery because they need to make sure all of that radioactive iodine is out of the system. The radioactive iodine is made to target only the thyroid gland. So this is going to destroy the gland, but luckily it's not going to destroy other body tissues. They start replacement hormones after 4 to 18 weeks after ablation, right? They're ablating the thyroid. They are basically killing the thyroid. It's no longer going to function. So unfortunately, the consequence of that is hypothyroidism. You're going to want to monitor for a thyroid storm, because when you give the radioactive iodine initially, the body's going to try to compensate. So it's going to cause this surge of thyroid hormone release. And this could potentially lead to increased symptoms of hyperthyroidism and even thyroid storm. And then you're going to want to educate the patient. They are getting a radioactive substance in their body. Because of this, they can contaminate their household. So you're going to want to teach them that they can contaminate through saliva, urine, or even just the radiation emitting from the body. So you want to teach them no sex and no sleeping in the same bed with another person. They need to avoid close contact with children and pregnant women. And they shouldn't share things like utensils and cups. The restrictions are based on the dose, so the higher the dose, the longer these restrictions are going to need to be adhered to. So they do need to talk to the prescriber and have the prescriber let them know for how long they need to follow these different precautions. So this slide is giving you a chart on some of the anti-thyroid drugs out there. The most commonly prescribed ones in the US are the first two listed, so your PTU and your methimazole. Okay. So they're both going to block or inhibit the synthesis of thyroid hormone, usually by preventing the conversion of T4 to T3. People are prescribed these medications until they are put in a euthyroid state. And as I mentioned before, anything drug-related, we're going to talk about way more in pharmacology. So this is just to give you a brief overview of what's out there. And then that second part of medical management could potentially be surgical management. And the two options are a total thyroidectomy, meaning they remove all of the thyroid gland, or subtotal thyroidectomy. With subtotal, they only remove about 5/6 of the thyroid tissue, so they leave a little left. And that little that's left is usually enough to keep someone from going into hypothyroidism so that they don't need to take a lifelong thyroid hormone replacement. A person who has a total thyroidectomy is going to have that lifelong replacement. They really reserve surgery, though, for special circumstances. They prefer treating with the pharmacological therapies. So they reserve it for people who are pregnant, or if they're allergic to antithyroid medications, if they have extremely large goiters, or if whatever reason they're unable to take antithyroid agents or have the radioactive iodine. Looking at relapse, when you compare the total versus the subtotal, the incidence of relapse with a total thyroidectomy is going to be 0%, right? There's no thyroid hormone being produced. Whereas they may have recurrence of hyperthyroidism with a subtotal thyroidectomy, but it's just about an 8% chance at 5 years. So usually, if it can be done, the preference is the subtotal thyroidectomy to prevent the person going into hypothyroidism. All right, so some potential nursing interventions would be monitoring those hormone levels, teaching them to perform regular exercises, avoiding environmental temperature elevations, avoiding goitrogens, so those are the medications and the substances that increase risk of goiter. They should decrease caloric intake when therapy begins because their metabolism is going to go back to normal. Ensure adequate iodine intake, receive regular follow-up, and of course education. And some of the things we are going to educate on is the importance or the impact of hyperthyroidism and its treatment. Letting them know that emotional lability is part of the disease. They need to monitor for any potential menstrual irregularities. Women have increased risk of osteoporosis, so increasing that calcium and vitamin D and monitoring for that. Let them know that long-term treatment and follow-up are necessary. And then the benefits and the risk of surgical versus radioactive iodine treatment. They should know about their medications, the names, the dose, the side effect, all those kind of things. They need to understand when to contact the provider, and then the changes in lifestyle that may need to be used. Any follow-up appointments, therapy, testing needed, and then again, support groups and health promotion, disease prevention. Then to evaluate, do they have relief of their hyperthyroid symptoms? Were there any complications, and are they following that therapeutic plan? All right, and one last thing is your question. So when assessing a patient who is returned to the surgical unit following a thyroidectomy, the nurse would be most concerned if the patient, 1, complains of thirst, 2, states her throat is sore, 3, holds her head when she moves in bed, or 4, makes harsh vibratory sounds when she breathes. And the winner is 4, makes harsh vibratory sounds when she breathes. That is a symptom of airway obstruction that comes from excessive swelling, bleeding, or hematoma formation. So it is very important that you monitor for this, and anyone who had a thyroidectomy, there should be emergency equipment at the bedside. So oxygen, suction, and a tracheostomy tray should all be at the bedside just in case this happens. And that's it. That finishes our regulatory endocrine section of the lecture. If you have any questions, if you're really unsure of anything as you're reading through this and you're listening to the PowerPoint and reading the book, please don't hesitate to email me or make an appointment to see me for office hours.